Good morning, everyone. So I see a few people out there. We'll give them a moment to trickle in, but I just want to say welcome everybody for attending the second annual AOT Symposium and Learning Collaborative, hosted by the Treatment Advocacy Center. We are the national mental illness nonprofit dedicated to eliminating barriers to timely, accessible, and effective treatment for individuals with a diagnosis of severe mental illness. I am Sabah Muhammad. I am Senior Legislative and Policy Counsel at Treatment Advocacy Center. I also serve as the inaugural DJ Jaffe advocate, and I also have two loved ones with a diagnosis of severe mental illness. So I know that whether you are an AOT champion, implementer, practitioner, or family like mine, you're here because you know that assistant outpatient treatment, or AOT, is one of the ways forward for our loved ones who are trapped in that revolving door of incarceration, homelessness, and hospitalization. And you're here because you know something works and you're hopeful. And that's how we remain, right? So on behalf of the Treatment Advocacy Center staff, I want to say how excited we are that we are here with all of you wonderful people and in person. That part is really, really amazing. And we'll be discussing our favorite life-saving topic for the next 2 days, assistant outpatient treatment. So our founder, Dr. E. Fuller Torrey, is not able to be with us today, but he wanted to extend his heartfelt greetings, and we have a video showing him.
It's my pleasure to welcome you all to the San Antonio conference.
Okay,
I'm sure I can't be there myself, but my Parkinson's disease makes it very difficult to travel now. I'm very happy that the conference is occurring. I think it's a landmark in terms of our efforts to improve services for people with severe mental illnesses. I think it represents the fact that the assisted outpatient treatment is a way forward and does not solve all the problems, but is a very big plus in terms of improving services for people with severe mental illnesses, especially those that are not aware of their illness sign. So I hope you all enjoy the conference, and I look forward to working with you over the years.
And now allow me to introduce Bexar County Probate Judge Oscar Kazin to formally welcome you to San Antonio.
Good morning, everyone. It's good to see everyone. Good. A good response, because it's going to dovetail into what I'm about to say. Some of you have already heard me speak, especially in the growth of AOT through the last, what, Brian, 14 years now, something like that, or somewhere in there. So before we start, and because you are in Texas, and as you've seen in Westerns, we have this thing called yee-haw. So you all gave me a great good morning. On three, I want to hear a really loud yee-haw. Here we go. 1, 2, 3. Yee-haw! We really don't do that. In fact, I don't think I've heard that since I was 12. And just so you'll know, I'll be playing all week, and I have 2 shows on Thursday. I want to welcome you here today. And when I say the last 14 years, I was just asking Brian Stetman. I want him to stand up. Brian, stand up. And I want to acknowledge him because I remember Brian 14 years ago when I first became a probate judge. I was a criminal court judge before that. And wanted to kind of do what we were doing in the drug courts and create an AOT court. It hadn't been done in Texas in the probate court, so we thought, let's give it a shot. Let's build something. And pretty soon thereafter, back in 2010, 2009, I met Brian, and he came and guided us, and TAC came and guided us in building this thing called an AOT. In fact, they made me change the name. And the reason I mention these things is I never would have guessed that 14 years later, those little seeds that were planted by Brian. He's like the Johnny Appleseed of AOT, that he planted in Texas and in Ohio, that TAC planted in Arizona, California. I never would have thought that I would see the day where I'd be in Texas, the least funded mental health state in the country. I'd be in Texas with a room full of people all sharing the same vision. This I can do as a judge. Each of you raise your right hand. Pat yourselves on the back. Good job. I've only got a few minutes to be with you. There's a couple of other things I'll be doing throughout the seminar. But if you're here for one reason. You're here because you care. We are the choir. And we're preaching to the choir, but I just am amazed at how big this choir has gotten. And each and every program, each and every judge, each and every provider, each and every doctor, caseworker, social worker who does what they do changes a life. There's a thought that life is much as a pond. Each ripple intersects the other. And we change the other ripple in invariable ways, incalculable ways. But my thought is, I'd rather be the stone that causes those ripples, the rain that changes its shape. Each of you are one of those drops. Each of you are one of those stones. When you've come to Texas, and the second thing and most observant thing I can tell you is that when you go to the Alamo, I can predict what you will say. It's so small. This room is bigger than the Alamo. But its stature, its reputation is huge. Many, many years ago, when I was first a judge, somebody came up to me and asked me whether I wanted to do a drug court. Didn't even know what a drug court was. And I thought, I don't want to punish people just because they're doing drugs. He said, no, it's something different. It's a therapeutic court. We're here to help people get sober. We're going to use our gavel to make a change. And I thought, wow, this seems like a good idea. But remember, this was back in 1999, 2000, 2002, in that time, when you wouldn't get elected in Texas unless you were tough on crime. Lock them up. I mean, I wouldn't have even become a judge had I said, let's help people. But think where we are 20 years later in the drug courts. Every jurisdiction, every source of funding, every mechanism is built to have them sustained and succeed. And this, for Brian and I'm going to speak for Brian, for us to see a room like this from across the nation, where will we be in 10 more years? We are changing the nature of how people with mental illness are treated. And truthfully, it's not about punishment. It's not about compelling. It's about making wellness their habit. And it's about having people that care and give enough of their heart and their soul to make that difference. So I welcome you with a yeehaw! And enjoy yourselves. We'll be walking around through all of this for the conference. If you have any questions for us, please let us know. Thanks for being here.
Thank you, Judge Kazin. Judge Oscar Kazin was the driving force behind Bexar County's AOT program, the first community in Texas to create a court-centric AOT model. So we are very honored to have you here with us. And we look forward to having you back up on stage tomorrow to share your wisdom and expertise. We also have, in addition, we have an incredible lineup of speakers, including another San Antonio resident who I haven't seen yet, advocate extraordinaire, Eric Smith. Where are you? Oh, there you are right at that table. And then we have other experts like Dr. Amador. I have not seen either. Am I missing you too? Dr. Amador is CEO of the Henry Amador Center on Anosognosia, the word we all come to learn sometimes through great difficulty, I know. And my friend Corey Minor Smith is here as well as one of our great celebrated speakers. She is a celebrated author and family member. There are many, many other speakers here, and we have a program rich with thought-provoking presentations, content-filled workshops, and stimulating discussions. If you want to take a moment to get acquainted with the information in your tote bag, you will find the program, which has all of our speakers listed inside. Also, a number of really important items. Hotel map, because it is deceptively large in here, and if you haven't taken a tour already, you will find out. So make sure you see that inside of your bag. There's also the speaker biographies and all the items that you will find very informative. Really great AOT information is in there as well, and the feedback form, which we really, really look forward to getting back from you. To make the best of our limited time together, we won't be providing detailed introductions to all of the amazing people here today, but like I said, the biographies are inside, and you will be impressed, as I always am, to work with the impressive and wonderful people in this room. Now we have some more housekeeping to get to, so make sure at least one person at your table is not zoning out, so they can get all the details and give them to you, okay? So very, very important, the most important part, please take a moment to make sure your cell phones and other devices are on silent. Also, if you decide to take a walk around with a refreshment, the hotel has asked us to remind you, please no glass in the pool area. Most important thing, if you are here and you need continuing education credits, we want you to know that 10 units are available for anyone holding social work, counseling, peer support, psychology, and attorney licenses. We can issue a certificate of attendance if you are unlicensed but want the credit record of your attendance. If you would like a certificate, this part is really important. You must complete the survey at the end of each day so that we have a record of your attendance. And you can use this QVC code on the back, a QR code, sorry, on the back. It's a 4-minute, what is QVC? It's the 4 minutes, it's really short, but you must do it each day so there's a record of your attendance. And it works, I already tried it out for you so I can tell you where to go. So that's really important. Other really important thing, we ask you to let us know during registration if you would like to take a riverboat cruise, and those tickets are available. $10 cash only. There's an ATM down the hall before you get to the registration table. During lunchtime, we'll be selling the tickets for the cruise. Boat rides are limited for the ones we-reserved, but you can catch a boat on the river if you want to. It just won't be with the ones that we reserved. You can meet us out front starting at 7:30 in the lobby, and we'll be walking groups over. If you miss us at 7:30 in the lobby, then just meet us right there in front of the Hyatt at 7:45 is the appointment for anyone who registered to get the boat in advance. Next thing that is really important, this part also really important to me. We are hoping to get an idea of the number of family members who are planning to attend the family focus group during session 2 this afternoon, so we can know how to set up the room. Because we don't have a count, if you are interested or planning to attend, please right now raise your hand and keep it up so Brooke can take a count so we can get an accurate setup of the room. If you get tired, you can switch hands. All right, thank you so much. You can put your hands down now. And finally, we have a videographer and photographers here. And if you do not want to be in the camera, in the frame, because these will be appearing on our social media outlets and website, then please just let everyone at the registration table know, and we can seat you away outside of the frame. And that is it for housekeeping. Hopefully everybody got that down. So now it is my honor. It is truly, truly my honor to welcome Treatment Advocacy Center's Executive Director, Lisa Dailey. Lisa is a national expert on assisted outpatient treatment, and she will share her vision for how AOT fits into the continuum of care for individuals with a diagnosis of severe mental illness. Ooh, that last step is
is a steep one. Welcome, everyone, and thank you, everyone, for coming. It's really great to see everyone, from family members to practitioners to judges. All of the people who have been here are an important part of making AOT work. So I welcome everyone and thank everyone for coming. And I'm waiting for my PowerPoint to start. But so I'm just going to talk a little bit about what my basic topic is. I'm going to be talking about where AOT fits into the continuum of crisis care, and specifically 988. A lot of you are probably aware of 988 being in the news constantly and people talking about what it is and having probably sort of a nebulous concept of what we actually mean when we're talking about it. So basically, 988 was sort of envisioned as being something that was going to kind of replace the National Suicide Hotline, but the intent behind it is broader than that. And it's something that I think there's been, a lot of kind of discussion about whether or not states are ready for it, without as much discussion about, what are we trying to do with it? And for our purposes here, where does AOT fit into that? As I really haven't heard a lot of conversation about that, but it's a really important part of a continuum of care. In fact, needing a continuum of care is one of the big reasons why AOT exists. So it's something I just wanted to touch on a little bit. I'm gonna go through my slides, and then I'm gonna reserve some time for questions with people if you want to ask any questions about your thoughts about where AOT should fit into the continuum of care. So just to give you a really brief overview, there's been discussion for many years about having a 3-digit number for psychiatric crisis, SUD crisis, basically something as an alternative to 911. And the idea behind that is just to try to do something that is better suited for the kind of response that you need for that kind of a crisis, as opposed to 911 being the only option that's available. So basically, the designation for the number occurred in July of 2020. And in October of 2020, the actual act was signed into law. So that was the point at which we knew this was going to be happening. There's been a lot of plans in place, but there's a lot more plans that need to be laid to make this a reality. And July 16th, 2022, this last July, was sort of the launch date for 988. And, you probably have seen some articles about there's massive uptick in numbers of calls from what maybe were anticipated. And there's been some discussions about where some of the glitches are. It's going to be sort of an ongoing process, but just want to talk a little bit about where the potential is for AOT in the 988 crisis continuum. So basically, I'm going to start with the money. There's been $500 million in federal funding so far that has trickled down into the system that is supposed to be designated for crisis continuum of care issues that are related to this changeover to 988. You can see sort of what the breakdown is. A lot of it came from the American Rescue Plan. There's been one-time dollars. Now, these are not continuing allocations. So most of them are one-time, block grants and that kind of thing. And there's quite a lot of talk about needing an additional round of funding. There is a lot of legislation that's being contemplated that would put standards in place to kind of discuss, what does 988 need to be at the state level? What does it need to encompass? And how are we going to kind of maintain a system that encourages the best kind of system and is able to collect data so that you can analyze how it's doing? So I think we can probably anticipate that there are going to be more federal funds. Who knows how long it will take to actually wind its way through Congress, but there are several bills that are being contemplated, and they are large dollar figures. So it's something that we, as people who are often looking for dollars to figure out how to launch programs, should be aware of, that this is going to be an opportunity. And sometimes we need to be a little bit creative about where you apply for funds for AOT programs. They don't necessarily have to be, the AOT fund in order to apply. These are programs that, if you can make an argument for why an AOT program might fit into a 988 implementation, you might be able to get those funds. So I just want to put that idea out there so people can be prepared and ready to ask for those dollars when they become available. So just to kind of talk a bit about how 988 and AOT kind of go together and where they fit into the crisis continuum of care. Basically, the overarching goals of 988, and it's not just to have an alternative to 911. The idea is really to provide a broader spectrum of crisis care at different stages of crisis so that you're really not having only the option of waiting for people to get to the point where you have either the option of calling 911 or calling 988. The idea is to be able to call earlier, to get involved with services earlier at different points in your continuum of crisis and your continuum of care. The idea is that access should be expanded through the use of 988, and that means that there's going to be a need for more programs. There's going to be a need for better coordination between programs. There's going to be a lot of new on-ramps to get into the system, and that's all going to have to be built out. It doesn't exist currently, as we all know. So it's going to be an active process to keep it going. Another big goal of 988 is basically to really provide funds and incentives for states to sort of re-envision what their crisis system looks like. I think most people can agree that the crisis system in almost every single place is a disaster and doesn't work. So what we really want is we want to see people take this opportunity of 988 being something that is required of states to figure out how to make this implemented at the state level as an opportunity to kind of rethink how they do things, kind of figure out how do you coordinate things to get people through the system so that the outcome of the individual is what you're focused on, not like what is happening at each stage of it. And obviously, one of the big overarching goals is to decriminalize our response to psychiatric crisis. And that's something that I think most people are happy to agree on. The question about how you do that is a very broad one and very open, and it's going to be state specific. Everybody has different laws at the state level, so how this looks at the state and city and local level is going to vary quite a bit. But the idea, is really gaining a lot of steam that what we really need is we need to figure out a way that people who are in psychiatric crisis can expect a medical or a treatment response rather than just a law enforcement response, or that law enforcement has a way of getting people into the treatment system, because I think most people in law enforcement would agree that that is what they want to do. There's not a desire on the part of law enforcement to arrest and incarcerate if there's a way to get people into treatment. That's an acknowledged reality within law enforcement. So everybody seems to basically be on the same page that this is what we want. So the question is going to be, how are we going to do that? And what is that going to look like for my state, my locality? And obviously, what that is actually going to require is that our broken patchwork of different programs are going to have to start to function as a system. And I'm not saying that 988 is going to make that happen, but we have an opportunity and we have momentum, and we're going to have money to try to put behind that goal of trying to coordinate services. And I think if there's one thing that people already know about AOT, is that AOT kind of does that. It sort of works in the way of forcing the different siloed parts of the system to work together. So if nothing else, AOT is a really good example of how this is supposed to work. So, a really good functioning AOT system is a great way to start creating a system and creating those dialogues between the criminal justice system and the treatment system, and between the medical system and the treatment system. All of those things are going to be a great way for people to kind of figure out how this is supposed to work. So, with a psychiatric crisis, when we have a heart disease issue, we kind of know how that's supposed to play out. There are prevention issues. There is, like if you do have a heart attack, you kind of know what that means. You go to the hospital and you have a certain kind of treatment. There is an expectation that there will be discharge planning. There's follow-up care. You adjust as you need to go. And then, the expectation is that if you are able to maintain your health, that you don't go back to the hospital. Well, that's what we want for psychiatric care. We want something that makes sense and that is predictable and that treats psychiatric conditions like health conditions, which is what we know that they are. So this graphic is something that I poached from another publication, and it kind of describes what we're looking for as a goal crisis response continuum of care. And just to walk through it real briefly, what we're really talking about is you can see that this is not all oriented towards emergency care. This is oriented towards providing a lot of on-ramps to the less restrictive types of care, to voluntary services, to outpatient programs, so that people can get treatment and get access to psychologists and psychiatrists when they're actually in a position to be looking for them, which I think we can all agree is not something that the system does very well right now. And as a result, people are remaining untreated or undertreated for longer periods of time, and that ends up creating, going into the next stage of crisis. That, what this is going to look like under, sort of the 988 system is that we're going to have new call centers. The people at call centers are really intended to be able to diffuse some of those situations by phone. Evidence does show that that is something that is a reasonable expectation. If you have people who are trained to do that at the call centers, that should be a reasonable possibility. You can anticipate that a small number of the people who cannot be diffused in that way may be, well served by a mobile crisis team. We're going to need a lot more of those. I think most people can agree that, you add one of those in a city, it can really have a huge impact on who ends up being able to be served within their home without having to go further in the system. But if people can't be served at that point, we do need to have an option for people who are in more acute stages of crisis, which means we need to have places for people to go. So we need to have, a crisis stabilization unit. We need to have hospital beds that are sufficient for people to come in, be evaluated, and be properly stabilized. This is something that I think most people acknowledge we don't have enough of that infrastructure, and we are going to need more of it. And then, basically one of the places where AOT is the most useful is you go back to the community, what are your options to make sure that a person is able to maintain their level of treatment and stay healthy and thrive within their community, so it's not likely that they're gonna immediately start to escalate and go back into the revolving door of care. So as we all know, AOT is excellent at that, and keep people stable, making sure that the services remain available. And that's not just about making sure that people continue to receive treatment. It's about making sure that the system is not allowed to drop people who have been prioritized as needing that level of care. It's a two-way agreement. So these are all things like this. If we are able to achieve this kind of a crisis continuum, we're going to see a lot more successful outcomes where people are not going right back into the hospital, and we're not having people who are only being seen for the first time in psychiatric crisis by law enforcement, which is a bad matchup, and everybody knows it's a bad matchup. So why is AOT a great match for what we're trying to do with the 988 continuum? Well, look at what it is that you're trying to achieve with AOT. You want to prevent people from remaining in untreated psychosis for long periods of time. You're trying to prevent people from going right back into the hospital because they are not properly stabilized. You want to prevent people from ending up in jails or prisons. So obviously decriminalization is a big part of the goal. You want to reduce the amount of time that somebody spends unhoused. You definitely want to prevent people from being out in the community and subject to being victimized by other people because of their unique vulnerability. You definitely want to prevent people from being in a state of despair so that they're likely to engage in self-harm or harm towards others. You want to make sure that the people who are being neglected by the system, who are basically, falling through the cracks where they're not achieving any kind of voluntary treatment, have some way into the system that is not through criminal justice. And that's what I mean when I say discrimination and access. So, if you've got like people in poverty, people of color who are typically the subject of discrimination in the medical settings, you can get into treatment through AOT. AOT is an on-ramp into treatment, so that does, and the idea is to keep people from only interacting with law enforcement. And then, of course, one of the big things that we have as a goal for AOT is to make a non-responsive treatment system, which can be the medical system or the county or the mental health systems that are, kind of really supposed to bear the largest burden in getting people into treatment. If they are non-responsive, you have an alternative into the system, and it is supervised by courts. Which is, I think most people can agree, something that is sometimes needed to make sure that people don't continue to be ignored by parts of the system. So the good outcomes that we're trying to promote with AOT are obviously very consistent with what we're also trying to do with 988. We are trying to keep people engaged in treatment, get people engaged in treatment, ensure that they, are really given every opportunity to receive treatment that can prevent them from continuing to escalate or ending up in situations that are dangerous for themselves or for anyone else. We want to provide system accountability, which I was just talking about, basically the idea of like systems that really are not set up so that they have to serve people. They can serve people, but they don't have to. There's a little bit of accountability that you put in the equation by having a court order and by having a neutral judge in a position to kind of see what's going on and to say like, nope, you don't get to drop that person. We've identified that person as somebody who's deserving of a higher level of treatment. We're going to keep following that person and make sure that they are receiving what they are entitled to. And we've got definitely the goal of diverting from jails and prisons. one of the big goals of AOT is to allow for early intervention. That can be either at the front end of the system or at the back end of the system. So, like say you're stepping down into the community from a hospital on an AOT order, the idea is that if something starts going wrong with that person, there is someone who is aware of that. We are not waiting for that person to devolve and, get sicker and sicker into the community until they again meet the very high standard of being brought into the system. There's somebody who's going to be aware of the fact that somebody has missed appointments, is not, maybe not getting the prescriptions filled. Somebody is not managing to see their psychologist. And that can be either because something went wrong on their end or something went wrong on the other end. So the idea is to be able to course correct quickly, rather than waiting for people to go back and forth between a high level of treatment and no treatment at all until they get very sick and then have to be in emergency care. That's what we're trying to prevent. We are definitely trying to force a continuity of care, and that's what we mean when we're talking about the continuum of care. We're trying to prevent 911 calls unless it's actually necessary. Obviously, that's always going to be part of any system. There will need to be an ability to call 911 in certain circumstances. But if you can do as much as possible to serve people earlier, that will be a smaller number of people, and you will have a less stressed system that is less likely to result in bad outcomes. When there's an interaction between people who are in psychosis and law enforcement, that's an unpredictable situation that you want to prevent as often as possible. And then basically the overarching goal of AOT, and which AOT is extremely good at, is coordinating care between silos that don't talk very well and don't have always good working relationships. All of those things will serve the system of 988 just as well as it serves people who are in, so basically AOT serves all of the same functions that 988 does. And so where does AOT fit into the crisis continuum of care? It fits everywhere. There is basically, when you look at the idea, like you can enter AOT at the beginning of this service, right, as a community-based care. You can step down from the highest level of care into AOT. And if you're under an AOT order during any of the other times, like if you're calling the call center and you're under an AOT order, you already have a care team. You already have people who can help you, who may be able to prevent that from becoming a 911 kind of a situation, or might be able to help you course correct and figure out how to troubleshoot and figure out, oh, okay, something's wrong with my medication. I need to go back and have this figured out again. You want people who are allies who can help you do that. The system is not responsive to individuals, and I think everybody has seen that to be the case. So in order to be successful, what do we need to do as AOT advocates in trying to make sure that AOT is really incorporated into our states and our localities' 988 planning? Well, first of all, we need to address infrastructure needs, and this is something that I think people have tended to overlook in our implementation of 988. If the idea behind 988 is that we are going to take a large group of people who have been inappropriately funneled into the criminal justice system, and we are going to force the system to move that population back into the healthcare system and back into the treatment system, it means we're going to have people that we don't have capacity for within that other part of the system that was supposed to be serving them in the first place, which means we need to increase all of our infrastructure. We're going to need more beds. We're going to need more programs. We are going to need more workforce. And those are things that we're going to have to be very vocal about with our legislatures to make sure that the plans that they put in place for 988 can actually work. Absolutely nobody is going to benefit from a 988 system that's just a number change. We need something that actually transforms the system. And I think it's inevitable. We are going to have to transform the system. What we have right now is not sustainable. So let's try to do it sooner rather than later. And it's helpful sometimes to think about the analogy with 911, because 911 didn't happen overnight either. When that went into place, it took years to get to the point where calling 911 means the same thing no matter where you are. And eventually, we are going to have to get there with 988, but it's going to take a lot of effort, and people are going to have to pay attention to what their states are doing and what their plans are to make sure that they're not creating a recipe for failure. We don't want to have to course correct if we can set it up correctly in the beginning. And that means that we are going to have to really keep an eye out for where there are federal funds that are available to fund AOT programs. As I said, AOT is something that can show a system how to coordinate. It can show the different siloed parts of the system how to work together. So it's a great place to start to like really start coordinating care and getting a continuum. And we know that there are going to be federal funds that are available. Federal funds are a little strange because sometimes you can get giant chunks of money without a whole lot of idea of what you're supposed to do with them. So let's give them an idea of what to do with those funds. And let's have our plans ready to apply for those funds and roll out programs and help the system learn how to work together the way our programs have already been able to do. And then finally, let's make sure that we are building into our programs the ability to collect and analyze data so we can prove that it works. Because if there's one thing that is really fantastic about advocating for AOT when you go to legislatures is that we have data. We can show that it works. You can prove that people are spending fewer days hospitalized. They're spending fewer days homeless. They're spending fewer days incarcerated if they're enrolled in AOT. And a lot of programs don't actually pay attention to the outcome data, but we do. And we need to, because outcomes are what matters. I don't care if somebody has a good experience in part of the system and then they become homeless. The outcome is what matters, and that's what we need to focus on, and we need to teach the system to focus on that too. Okay, so I don't know how much time I have, but if anyone has any questions about 988 and AOT, I am happy to take them. And then also just wanted to mention that if you want to be involved in advocacy around 988 and how to incorporate AOT into that, I encourage you to get in touch with our staff. With our implementation staff, with our advocacy staff, really anybody at the Treatment Advocacy Center, and we'll try to help you figure out how to plug into your state level 988 implementation. And we're gonna do our best to track federal funds that are available to give people a heads up that it's time to put your proposals together and to apply for those funds.
I'm very excited about the 988 prospects. I come from a jurisdiction, and I don't know if there are any other municipal court judges here, but I'm here because we see the need. We see it on an ongoing basis. Statistically, whether anybody knows or not, when it comes to anyone who ever sees the inside of a courtroom in their entire lives, 80% of them are going to be coming through a municipal court. And when they come through, they have finally offenses which don't seem very significant. However, attached to those individuals who are accused of Class C misdemeanors, and I'm talking about public intoxication, criminal trespass, minor theft, fighting, assault, they sometimes, and many times, have attached with them some behavioral health challenges that seemingly, and where I am in Irving, you know, we're an international city. We've got an international airport. We got a great transportation hub, and we're seeing people from all over the world. And they happen to come into Irving, and they've been where they've been, and somehow they have been manifesting or presenting that behavior, and for some reason, either they haven't latched on or there hasn't been any traction on them pursuing services that are needed, but they come to Irving and they, you know, basically expect the same as they've experienced elsewhere. And we take the position that if you're going to be coming through Irving, 988 would be perfect for us to be able to engage, because we adopt that sequential intercept mapping module. We have our own behavioral health leadership team in Irving because it's such an international city. I mean, it's got the most diverse zip code in the United States there. And the thing about this is that statutorily speaking, it seems like it's an oversight that when people that have needs or whatnot, statutorily the law just kind of skips over those Class C misdemeanors, because if you look at early identification of people with these mental illness or intellectual disability, it starts with if a person is charged with a Class B level misdemeanor offense or higher, then you can impose this, order to get them interviewed and what have you. When it's a Class C, people expect you to get them out of there as quickly as possible. And of course, when that happens, then you can expect them to go round and round and round. And I've seen some people as many as 30 times. And all I can do with them is incentivize them. And we do a very good job of incentivizing to get people to pursue services because we tie that into their disposition and we give them actual credit for doing that. But I was just wondering if it's not a good idea to maybe incorporate more and more, or at least broaden the horizon in terms of people that not only can benefit from this, whether they have a criminal offense or not, but if they do, to pour more resources into the municipal court level, because when we get someone engaged, the outcomes, and we need to have more empirical data, but the outcomes anecdotally are nothing short of miraculous. So
I would completely agree with that, and I would also say that you need to come at this issue from various different. Like, first of all, we need to have better ways to keep people from actually being booked. I mean, if you pick somebody up on the kind of very low level crimes that are associated with somebody who has untreated mental illness or somebody who is unhoused, a lot of those things really don't need to be things where somebody actually gets booked and end up in court, because I think we can all agree that once you end up in the court system, it's tough to get out. The court and the jails have sticky fingers. It is tough to get out of there once you're in there. So we need more avenues for people to actually get people into the healthcare system, and law enforcement is definitely in favor of that. I mean, it is not a good match to have people in jail who are untreated. They're very difficult to get proper care for, and it's definitely something where you want to come at it from every possible angle. So I completely agree with you, and there are a lot of ways in which there are it goes the other way too, where there's a focus on diverting people who are only charged with nonviolent offenses. And if you think about what we're doing, if somebody has engaged in some kind of conduct that could be considered a crime, even if it involves an element of violence, which could be resisting arrest, that kind of a thing. If they're engaged in that conduct because of untreated mental illness, do they deserve an opportunity to be treated instead of incarcerated? Yeah, I mean, there's definitely a lot of ways in which we set up very limited ways for people to get out of the criminal justice system into the treatment system, and we do need to look at all kinds of ways to broaden that, so that we can really come at this problem from all over the place.
Am I on?
There.
Yeah, hi, Janet Hayes, New Orleans, Louisiana. So absolutely appreciate what the judge, I assume municipal court judge, was saying from Irving. And that there needs to be some sort of rule, and I think to advocate for evaluation on discharge, or when somebody's coming into the criminal justice system, they should immediately be considering AOT. They should be evaluated to see if they're appropriate for AOT, and if they are, then to be connected to AOT. But my question is about the psychiatric deterioration standard. So in Louisiana this year, we got passed a law that says that psychiatric deterioration can be considered as a criteria for involuntary commitment in addition to danger, self, others, or grave disability. I'm just wondering, in terms of how that actually works, are there any counties, any parishes that have actually implemented that standard, and how is it being used in conjunction with AOT? So if somebody's not dangerous, self, others, they're not gravely disabled, meaning half dead yet. The parent or the maybe a petitioner recognizes deterioration. How do, so as far as the issue of police not being involved in transport for someone like that who needs hospitalization, is psychiatrically deteriorated, but also has anosognosia, still does not want treatment, all of that kind of stuff. There's a lot of questions, right, about how to implement this standard, and just wondering if anybody's done it and how it works with AOT.
I mean, definitely there are places that have done that. And obviously there are places that have, a shared criteria. So like their inpatient standard is the same as their outpatient standard. So, you'll see a lot of places where if psychiatric deterioration is part of their inpatient standard, it's also part of their outpatient standard. And there are ways that has been, achieved in terms of how that works. And I would say that a lot of where we run into problems with that, and one of the ways that we can address that is with training people on what those criteria actually mean. So when you're talking about somebody who has met the criteria for psychiatric deterioration, we're not saying that that person isn't a danger to themselves or a danger to others. What we're saying is that they are a danger to themselves or others because of the psychiatric deterioration. And there's a lot of misunderstanding about that. So part of it is making sure that all of the people who are called upon to interpret those criteria understand what that means. And if people are all on the same page, and this is, we've kind of been looking at different ways that you can address that. And, how do you make sure that people, because as we all know, people who actually interpret the criteria are not all doctors, they are not all lawyers, some of them are law enforcement, some of them are social workers. We need to all be on the same page about what that actually means. And there's a lot of different ways to achieve that, but that's the place to start. I mean, there are states that have fantastic criteria, but they don't use them. And they don't actually, like what they actually do on the street is not what it actually says in the statute or in the case law. I mean, why would anybody know about what the case law is? Like if you're not a lawyer, you don't know that. So like a lot of this can really be addressed through really careful and well-attended trainings. And it's gonna take a lot of engagement to make sure that all of the stakeholders that have to be on the same page are part of that. But I think that that's the key to getting people to like correctly use that criteria, is like really bringing them together and having people have a conversation about what those criteria are supposed to mean, so that you recognize it when you're looking at somebody who is meeting criteria. I mean, it should mean the same thing in every part of the state. When somebody's looking at the criteria, it shouldn't matter that you're in one county versus another. And it's a big hill. I mean, like it's gonna take a lot to get all the people on the same page, but it's really the only answer. Oh, we've got somebody waiting over here.
Hello, thank you. So your conversation was a lot about what I paraphrase as the 988 is the new 911. So with that in mind, and the ability to share information, I'm really curious about, so I'm gonna throw this term out, the 21st Century Cures Act data interoperability, basically guidelines about how is our health information shared, and that it shouldn't be a roadblock. Where's the relationship between that, or how do we think about that, and sharing health information at the right time with the right people with the right permissions? Because this is not a HIPAA violation. When people are in AOT who come in contact with the criminal justice system, who are in our program, we are not notified because we don't have that infrastructure. So can you talk a little bit about where you think those intersections are and how we might be thinking about it?
Well, I'll say that the 21st Century Cures Act was basically like using a process to try to achieve a different outcome that wouldn't have been necessary if people were actually reading things that are already in the guidance. So, HIPAA actually is pretty clear about there being a pathway to share information. The problem is that we don't have a way to incentivize healthcare providers to do it. It is possible, but it is not required. That is always a problem with the way that we implement all of our social services, because we give people in social services and the treatment system tools. We don't require them to use those tools. So there's a lot of debate about, I mean, there have been a lot of discussions about how can you clarify the HIPAA guidance? How can you make sure that it's clearer that that there is a pathway to share that information? And I know some states have gone about it by incorporating into the court order that there are releases, or requiring that people sign releases. But what we really want is again, for people to understand what the guidance says and to follow the spirit of it in the way that it's intended. And we might need to find better ways to incentivize it. We might need to find better ways to get healthcare providers to not be so frightened of it. I mean, like, nobody ever gets sued for a HIPAA violation, and yet it's the one thing that you can count on people to kind of raise as, well, I can't do that. I can't share this information. And it's just like, well, and then if you can show them the guidance where it says, but this falls within an exception, you definitely can, but they don't have to. So I think we're gonna have to find some carrots and maybe some sticks, but sticks are hard to come by when it comes to the medical. They're pretty good at avoiding the sticks. So maybe we can find some good ways to incentivize people to share information. And everybody basically seems to agree that you get better outcomes if you do that, but they still don't really do it. So I agree with you, that's a big hurdle.
Microphone on? Yes, okay. I just wanted to make a brief statement of something that is good in our county, Orange County, New York, that we had a mom, and someone can maybe feel empowered, that she started a program, hope, well, it's an organization type, hope not handcuffs. And that's exactly what you were talking about with diversion before even getting booked. And the volunteers that work there is grown to large amounts. I can't remember the amount. I want to say a couple hundred people, but they consider themselves angels, and they are called in by law enforcement to deviate. So that's just, one person making a big movement.
And what I want to point out about like why that probably works as well as it does is because you're not setting up something in order to, like you're working collaboratively with law enforcement and acknowledging that everybody basically wants the same thing here. What is lacking is, easy ways for that to happen. And that's another issue that is like part of the siloing problem. It's, I would definitely never say that, the issues that we have with criminalization, it's not happening because law enforcement really wants to be taking over the role of healthcare and treatment. It's happening because we've made it really easy for everybody else to pass on it. And then when you call 911, somebody has to come. They don't have that option. That's how this is happening. It's not happening because there's bad will on the part of law enforcement. So if you partner with them, they will work as hard as they can to get something that works, to get people out of their system and into the system that people really belong in, which is treatment or medical care.
Thank all of you. My question is not how, but who makes the determination that a person needs AOT? Is it family, medical people? Is it through jails only, or the criminal justice system, or can a person request it themselves? I'm new at this, as you can tell.
So
I appreciate an answer.
It all depends on where you are, because as you know, we have 51 beautiful snowflake systems in the country, and none of them function exactly the same way. So they're all unique. So a lot of it depends on what your statute actually says. But as a practical matter, what it really is it's a place where medicine and the law overlap. And that's part of the reason, and that is also the case with all civil commitment criteria, is it's basically a medical determination or opinion that is also being, kind of given a review by the courts. And that's part of the reason why it's complicated, is because, there isn't 100%, ultimately a judge makes the decision about whether or not somebody meets criteria, unless somebody agrees to be part of a program, which is also an option. And obviously in AOT, that is usually what happens. But generally speaking, there will be a medical opinion about whether or not somebody is meeting criteria. The judge will review all of those circumstances, and then the judge will make a determination in order, create an order that is specific to that person. That's generally how it works. But there's a role for a lot of other stakeholders in the system. So basically, how do you enter the system? Well, that can be family members who kind of determine that, like, I think somebody needs to be evaluated. I'm going to contact the system. And then you have to figure out, like, what is your on-ramp to get into AOT? So you need to figure out, like, can you make a direct referral to the system, to the behavioral health department? Or can you contact the courts directly? Or can you really start, bugging your adult child's doctor to make a referral? So a lot of it is about kind of determining, like, what is the process in my state for getting somebody into this program, and then becoming an expert about it, because you can probably be guaranteed that other people that are necessary to the system are not experts in it. So then you have to teach everybody.
Okay, thank you. And one tiny other question that goes along with that is, can a person themselves request AOT, and are they present when the judge determines?
Well, I mean, a person is always capable of entering into voluntary services, so that's really what it is. And that is actually what usually happens with AOT, is that the process starts, a petition is filed, a person reviews the plan, and then, if you think about it, a lot of times this is a person who's in a hospital, they are going to agree to the outpatient order in order to get out of the hospital. So that's actually very common. So like definitely, voluntarily enrolling in AOT is always an option. A person always has that ability to do that.
Okay, but I guess what I'm getting to is, are they like coerced into treatment if they don't want it?
the judge has the ability to court order somebody who does not want to participate, so there is that possibility. But generally speaking, what ends up happening is much more likely to be that the services are offered, a person is aware of the fact that if they went to court and contested it, they probably wouldn't win, so they'll enroll. So is there light coercion? Yes. But at the same time, they are choosing to do it, so, and it's like, and that's not always the case. Some people do get court ordered into AOT. And basically that's one way of going into AOT. Voluntary enrollment is a way into AOT. The idea is basically just, these are services. They have the overlaying court order. So it's not that different from enrolling in voluntary services, but there is a person who's supervising it.
Thank you.
Well, we've got somebody waiting over here.
My name is Danu Sanasi. I'm from NAMI, Orange County in New York. And this recently happened in our county. The person was suicidal, and the mother called 988. 988 transferred the call to 311, which is a local call center. And they took him to the hospital. The hospital denied the services. And it happened twice. And the mother was so devastated. She didn't know where to turn to. So this is, and I did bring this thing to the 988. I was at one of the other conference. I did bring it up. And they are going to look into that because, waiting for transferring the calls to another place, it's not good for the person who is suicidal. The other thing about AOT, and I feel like there is a lot of misconception, there's a lot of misunderstanding, and also there's not much awareness about AOT. And I hear from families day in and day out how much they are struggling, suffering, not knowing where to get help for their loved ones. And I truly feel like the counties nationwide, we should be bringing more awareness about the benefits of AOT.
I agree with you on that, and I want to be really 100% clear that 988 it's not currently functioning the way that it needs to be. It's going to take a long time to get what we needed because a lot of what's missing in 988 is, first of all, there definitely are technical issues like that where people are being sent places that are inappropriate or calls are being dropped or there are area code issues where you get directed to the wrong place. There's also the fact that in order for 988 to work the way that it needs to work, we have to build up services that do not currently exist. So it is gonna be a bumpy road. It's just a bumpy road that we have no choice but to travel. And then what I would say generally about the awareness of AOT is that I really wish that counties were 100% bought into AOT and it was available everywhere. There are some states where it is available in most of the state, but generally speaking, I think it's going to be up to really successful programs to ensure that people in the state know about the successes and it becomes more widespread that way. And I am being signaled to stop, so I'm gonna stop. But I encourage anyone who wants to ask additional follow-up questions, reach out by email. Happy to have a conversation.
One more round of applause for Lisa, please. Thank you. Focusing on outcomes is the perfect vision that exhibits the flexible nature of AOT. Are you all ready to get back with me? If you have more questions, you can email them to Lisa or we can talk about them at the pool reception. We're a little late. I need you all to get back with me. You ready to keep the AOT show going on? I guess not. So next up, we have our newest member of Treatment Advocacy Center, Brooke Gentry, making her way up to the stage. She has a surprise for us. I don't even know what the surprise is about to be. But here she comes to let us know.
Hi, everyone. And thank you, Sabah. So I am absolutely thrilled that so many of you were able to share your personal motivations for AOT through our montage video, AOT Because. So thank you so much. And your powerful messages are gonna make up for my lack of professional video experience. So keep that in mind. But in all seriousness, we are incredibly grateful for your thoughtfulness and efforts on this project. So without further ado, I present AOT Because.
AOT because it keeps me accountable for my actions and it gave me the confidence to go back out and work.
AOT because commitment, communication, compassion, and community working together to help others be healthy.
AOT because we have a significant backlog of individuals with mental illness caught up in our criminal justice system. Many of these individuals face only nonviolent charges. AOT would be a significant, better alternative to help with long-term outcomes for these individuals.
AOT because treatment works, recovery is real, and we in the court are here to help you live your best life.
AOT because everybody deserves to have a voice. What AOT means to me is providing that voice that connects clients to resources that they need and the treatment that they deserve.
AOT because throughout my life, I've both personally and professionally witnessed the incongruencies and downfalls where mental, emotional, behavioral health, and law intersect.
AOT because I've seen the light in clients' eyes whenever they get their first key to their apartment, or they get a new job, or they want to become a peer specialist.
AOT because it saves lives every day.
AOT because as a treatment provider, it really allows us to intervene more swiftly when someone is decompensating. It helps increase compliance to medications and allows us to help keep people back into the hospital sooner if they are relapsing on their mental illness.
AOT because people matter and it works.
AOT because for the last 3 years, my family member has been on a restrictive and expensive conservatorship here in California. Had there been an AOT program in Sacramento County 3 years ago when he was conserved, he would have been able to stay in the community and get support from family and friends here. That would have also saved the county thousands of dollars that they could have used for other programs and to treat more people effectively.
AOT because it changes perceptions and it changes lives. I believe in AOT because I've seen the effects of individuals that come into my court that don't have anyone, that don't have any person to turn to or to believe in themselves. The AOT gives them a way of believing in themselves and allowing other individuals to come into their lives that are willing to help them and make their lives for the better. I've seen what AOT does, and I'm a believer.
AOT because it frees people suffering from serious neurological brain diseases to live their best lives and thrive. And they deserve no less.
AOT because this treatment can assist the mentally ill who don't recognize their illness remain a member of their community and continue care in an outpatient setting.
AOT because people living with serious mental illnesses shouldn't be in outdoor asylums, in jails and prisons, in revolving doors of treat, street, and repeat. It's so beautiful to be part of a program that frees people from hallucinations and delusions to give them their lives back. When we tell people our program is different, we mean it. Don't ever underestimate your power to change the status quo. Don't ever doubt that people in positions of authority want to see the same changes you do. Show them the way.
AOT because we empower people. We support others on their recovery journey.
We help people find their voice.
We are the change.
We believe in our people.
AOT because we care.
AOT because AOT is about reimagining what's possible for recovery. AOT because doing nothing is not enough to stop the revolving door of more restrictive treatment. AOT because introducing those we are privileged to serve to a new path beyond the revolving door promotes hope and leads to more enduring recovery.
AOT because
it provides a critical opportunity to engage family members in the care of their loved ones. The best AOT programs involve family members in the development of a person-centered treatment plan. Family members know what has and what hasn't worked for the individual in the past.
AOT because it saves lives, it makes a difference, and it helps people. When I was seeking recovery services and wellness for mental health, it was not available to me, and maybe I would have gotten help sooner.
AOT because AOT helps connect a variety of systems that haven't connected in a very functional way in the past. It obviously helps connect inpatient and outpatient providers. It helps families connect with providers in a way that's systematized. It helps clinical systems and legal systems speak to one another in the same language. And lastly, it helps providers from the inpatient side of treatment and the outpatient side of treatment collaborate much more closely. It's a pretty novel model of intervention in the outpatient landscape.
AOT because it saved our son's life and quite possibly mine when he had delusions of killing me.
AOT because the core component is an essential piece in cultivating compliance in the chronic mentally ill. AOT provides a layer of accountability that doesn't exist in standard outpatient treatment. AOT assists those patients that would otherwise fall through the cracks, and it helps SMI patients to access services, achieve more stability, and hopefully live their best lives.
AOT because no one should be left to suffer with an untreated serious brain illness.
AOT because it works. I've seen how having an AOT program allows individuals to escape the revolving door of hospitals and jails and enter into a meaningful life of recovery. AOT is a critical component that should exist in every mental health system.
AOT because my beloved son has fallen off every jagged edge of every broken piece of the mental health systems of California. Because AOT was not adopted, our son's lived experience included a blur of suicide attempts, over 40 involuntary holds, revolving hospitalizations, and incarceration. AOT because, if it's done right, it will save lives, money, and possibly our national soul.
AOT because it works. We have found that the individuals without the internal resources to stay engaged in treatment tend to frequent the hospitals, emergency rooms, and the jail. However, those who stay involved with the AOT program tend to stay away from those institutions.
AOT because everyone deserves a chance to live a meaningful life in the community. In the 2 years I've worked on AOT, I've seen people achieve goals such as getting a job or developing meaningful social relationships. Watching people develop insight through this process has been amazing.
AOT because it's time to stop the senseless over-incarceration of seriously mentally ill adults in our communities. Incarceration of the mentally ill is an old and a failed way of thinking. In a compassionate and civilized society, we must do better. AOT is the solution.
AOT works because those that have sometimes struggled with the continuation of their mental health care need the added support and assistance AOT provides.
AOT because mental health matters.
AOT because I like to make a difference in mental health.
AOT because I love to see participants graduate.
AOT because our communities deserve systemic change.
AOT because we inspire change.
AOT because it changes lives, not just the lives of the participants, but all of us, family, friends, and clinicians, because participant stability has been proven over time. AOT reduces hospitalizations, it reduces emergency room visits, and most importantly, it reduces the amount of interaction with law enforcement and jail time. For many people, it's the first time they've been able to maintain stability in a community-based setting in years, and they're living happy, healthy lives as productive members of our community.
AOT because everyone deserves a fair shot at success and happiness. AOT means to me providing support, encouragement, understanding, and compassion to help those struggling get that fair shot. It means meeting a person where they're at, helping as they identify their strengths, and using these strengths to help meet their goals. It means providing the best treatment possible to best meet the individual needs of every participant served.
AOT because it works. It's an extension of the continuum of care, involving judges and attorneys along with case managers and supervisors, providers. It's a team, it's a community, and it reminds the participant that they exist in community. AOT because it works.
AOT because bringing AOT into our community has allowed us to develop and provide access to a full fidelity treatment team as a warm handoff upon hospital discharge to provide intensive behavioral health services to involuntary treatment consumers. With the concept of being a hospital without walls, we are able to provide the 24/7, 365 care that's needed to give our consumers the best opportunity to live their best life while they're living in the community.
AOT because the National Alliance on Mental Illness reported that in 2020, only 46.2% of U.S. adults with mental illness receive treatment. AOT is here to help change that.
AOT because it's one of the best modalities of treatment we have seen. AOT because it's changing people's lives.
AOT because we believe that people affected by mental illness deserve to live healthier, more fulfilling lives surrounded by a community that cares. I've watched my 22-year-old son emerge from a dark, frightening place into a life where he can have meaningful relationships with the people who love him. This would never have happened without the support of his community and his AOT team. We need to take into consideration the inability of some people to make the best decisions for themselves. Our loved ones deserve to be treated as human beings and not as criminals or substandard.
AOT because this bench means more than just judgments. Because that chair deserves more than someone who just wants to get cases through. Because this box should not be filled with jurors waiting to punish someone or lock them away or institutionalize them. Because we as judges can make a difference in people's lives.
AOT because studies and firsthand accounts across the country have shown that AOT programs, when used and implemented, help to reduce hospitalizations, arrests, and homelessness. Of the 8.8 million adults who suffer from a severe mental illness, like both of my brothers do, they often experience anosognosia, or lack of insight into their illness, which leads them to get off their meds. And this undoubtedly begins the downward spiral that many of us family members know all too well. It is my dream to see those we love stop suffering and to have hope and purpose for a future that they've defined for themselves.
AOT because I was the first person to ever graduate from the AOT Assisted Outpatient Treatment Program for Richland County, Ohio. What AOT means to me is a renewal of mind, body, and spirit, and a systematic, holistic approach to helping the human person be all that he or she can be in his community and in his region. Thanks for listening.
Thank you, Brooke. That was fantastic. Fantastic. When will that be on our website or our YouTube? Very soon. Awesome. Thank you so much. So now it is my pleasure to introduce the people who we are all here and hopeful for, who give us the hope by, like Lisa said, connecting the dots for policymakers. Nothing connects the dots more than telling our stories and the story of AOT coming from the graduates themselves. So I am very, very proud to introduce Eric Smith, a nationally recognized health advocate, mental health advocate, and AOT graduate. During this session, Eric will interview Bradley Tarr, who you just saw, and he is the first graduate of the Richland County, Ohio program, and Dupree Taylor, his case manager. Come on up.